Good morning, everyone. We have a double header this morning, so we're going to start with education awards for our division for this academic year, and then after that, we will do a talk on lipids with Dr. Dave Saxon. And so Dr. Rita Lee will announce the education awards.
All right, everybody. It is my pleasure to announce the 2025 GIM Education Awards. Just as a reminder, this is generally for people who are kind of going above and beyond, in their work as educators. So in no particular order, we have Ingrid Lobo. She has been an LIC preceptor. She is a preceptor and attending in resident clinic. And she is receiving the award for continuing to foster scholarship with learners. When asked what I love about teaching, she says the aha moments when a student or resident finally gets it. Also, it's great when I don't see a student or resident for a while and I precept and I see the growth. So seeing joy in our learners' development. Our second awardee is Whitney Vukatic. She has been working extensively with our APP trainees and has dedicated over 340 hours in 2025 to teaching APP trainees. And what she loves about teaching is that she enjoys teaching in the clinical setting where learning is grounded in real patient care and clinical decision making. I like working with advanced practice providers to build practical skills in chronic disease management, preventive care, and patient communication while strengthening confidence and clinical judgment. I especially enjoy highlighting the nuance and personalization that go beyond textbooks and helping learners adapt care to each patient. The teaching relationship building is also important as strong patient connections are central to effective care. And she finds it meaningful to support APPs as they transition into a new professional identity and develop the confidence to think and act as primary care providers. So thank you, Whitney. And last but not least, Christine Neeb. As you all know, she has done a tremendous amount of training and leadership around substance use disorder. She created that CME series to meet our licensing requirements, and she has done an extensive amount of training for both our faculty as well as our residents. And she states, I am passionate about translating complex topics such as substance use disorder management in primary care into practical and accessible learning for attendings, residents, and students. I believe this fosters stronger physician-patient relationships, reduces stigma, and makes caring for complex patients more rewarding, helping physicians continue to thrive in in primary care. So thank you to all of our educators, in particular, congratulations to our 2025 awardees. And without a further ado, we'll have Dr. Saxon.
I'm not Dr. Saxon, but I'll introduce him. So we're really excited to have Dr. Dave Saxon join us today for hot off the press, this update to the Lipid Guidelines that came out just a couple months ago. And he's going to be talking to us about key changes that matter in practice. I don't know about you, but I've been trying to unravel what to do with these coronary artery calcium scores and ApoB and other updates and changes in these guidelines. And I think that at the end of today's Grand Rounds, we'll have a lot more insight into those things. Dr. Saxon did medical school at Loyola, residency at the University of Michigan, and then endocrinology fellowship here at the University of Colorado. Dr. Saxon is also the director for the eConsult program, as well as the ECHO program. And again, we're just really fortunate to have this timely topic. And so I will step aside so we can maximize our time for it.
Great. Thanks, Steve. Thanks for having me, and appreciate those who are here and those online. In advance, if I cough a little bit, we can thank my kids for a nice bout of strep throat about a week ago. So I apologize in advance for that. Again, thanks for being here. There's a lot to distill down from these guidelines, so I'm going to try to do my best to do that for you all. I have some disclosures. I have done some consulting work for Ionis, which is a company that makes triglyceride-lowering drug. Canica, you may know we have a lipid apheresis unit here on campus. We're the only place in the state that has that for people with severe lipid disorders, and I do work a little bit with that company, and then been a principal investigator, sub-investigator with these companies mentioned here. So learning objectives. I want you to be able to, well, I think you can already do this pretty well. All of you use the risk calculators, and we're going to talk specifically about the PREVENT ASCVD risk calculator. I'm going to try to distill down, as Steve mentioned, what to do with these coronary artery calcium scores that were now recommended to get in more of our patients. We're going to talk about advanced lipid biomarkers, specifically apolipoprotein B or ApoB, and then Lp(a), which is obviously a very hot topic. I'll hopefully shed some light on how to use non-statin therapies in conjunction with the guideline recommendations. And then at the end of this, I just want you to be able to integrate the main highlights into your clinical practice, and I'll summarize things at the end. So here's the guideline. I know all of you are somewhat familiar with them, and maybe you've tried to digest them in different forms. If you want to do the deep dive, I know Lisa Schilling told me maybe about 2 weeks after the guideline came out that she'd already read the entire clinical practice update. She's a better person than I am. I didn't read it that quickly. It's about a 130-page document, and it's a lot. But they did some really nice things like create this 2026 dyslipidemia guideline at a glance. That's about a 7-page document, and I have the QR code here. So if you go to the AHA website or any of the journals that have published this, there are some really nice things that have been created to help you incorporate these guidelines into your clinical practice and not necessarily have to read the 130-page guideline. So I would say there are many take-home messages, but I tried to break this down into about 10 of them. And I'll talk about all of these messages through 3 case examples here today. We're going to talk about how early intervention is important, and that's the main crux of the guideline, is that we need to start treatment earlier. We're going to talk about using the prevent risk calculator and what those scores mean. Again, talk about checking Lp(a), which is now recommended as a class 1 recommendation for all adults in America. We'll talk a little bit about ApoB and when to check that specifically in the setting of high triglycerides and LDL cholesterol discordance. Again, talk about coronary artery calcium score and how that reclassifies risk. We now are back to targets for LDL cholesterol, and specifically, even though we've kind of known this even prior to this guideline, that we should be targeting lower levels of LDL cholesterol for many of our high-risk patients. It's been formalized in these guidelines, LDL cholesterol less than 55 for the very high-risk patient with ASCVD. We're going to talk about using non-statins. And then a couple of things I'll just touch on at the very end would be that there's recommendations for more aggressive prevention in those with diabetes, CKD stages 3, 4, and those with HIV. And then pancreatitis prevention is important. Triglycerides over 1,000. That's something our lipid clinic likes to try to specialize in, and that's an important thing to not ignore in clinic. So the first thing is conceptual here. This is not actually in the guideline, but I think it's worth touching on that. One way to think about what we're doing here from a prevention perspective for lipids is thinking about a concept that's similar to pack years of smoking exposure. So you can think about atherogenic lipoprotein exposure. So if you look at this figure, in green is a line that's showing that if someone has an LDL cholesterol of 80 from a young age, the threshold of exposure to those atherogenic particles over their lifetime hits a threshold where we start thinking about people getting MIs maybe not till around age 100. That would be that top dashed line. If you have an LDL cholesterol for life that's around 125 milligrams per deciliter, which is about the average LDL cholesterol for an American, you might start seeing what we see in practice generally, which is people starting to have heart attacks generally in their 60s. And then the red line are those who tend to have severe primary hypercholesterolemia, or often genetically have familial hypercholesterolemia, which is a disease that impacts about 1 out of every 250 people in the world. And those are people who can have MIs in their 30s or 40s because they've been exposed to these atherogenic particles. So I just like this conceptually to think about that exposure to these bad particles. I'm going to get into particles a little bit here because this is a smart audience, and I think it's worth understanding this. But the guideline points to we should really work on primordial prevention. And when we say treating people earlier, a main focus of this guideline is really starting to think about this risk when people are at age 30 or even younger. And the prevent risk calculator starts to give us risk scores at age 30 as opposed to age 40 with the pooled cohorts equation that we used previously. So this is a central figure that's in the dyslipidemia guideline at a glance, and it's talking about, even thinking about, for those who maybe are here who've even seen kids historically, thinking about how do we screen children. We should screen at age over 2 For those who have a family history of premature ASCVD or have known familial hypercholesterolemia. In general, most of the population should be screened for a lipid disorder between age of 9 and 11 years old. And then once you hit adulthood, so after age 19, we should be rechecking lipid panels every 5 years and using the Prevent ASCVD risk calculators I already mentioned. One thing that stands out there for me is sometimes, we actually overuse, right, lipid testing. People just come back every year and we get their lipids every single year. If things have not changed with someone's health, you really don't need to do that. A healthy 19-year-old Prevent score is low. Their LDL cholesterol is good. Maybe check them again in 5 years. The next part here is aiming for lower LDL cholesterol value. So as I already mentioned, we have a target now for the very high-risk patients to aim for LDL cholesterol is less than 55 milligrams per deciliter. And there's much more aggressive turn here towards, for a larger percentage of the population that are high risk, high coronary calcium scores, those with diabetes, making sure we're driving LDL cholesterol down below 70. And then lastly, thinking about just treating people longer and thinking of, as you all do, about adherence to these medications. Here it says in that first bullet, check lipids 4 to 12 weeks after starting a dose change. I'll tell you in practice, I usually, once I start a statin or any therapy, I'll check, well, really, once I start a statin, I'll check an LDL or lipid panel 4 to 6 weeks later. I think waiting 12 weeks might even be too long. I think patients respond really well to seeing their numbers after they start the therapy, especially because a lot of our patients are hesitant to take statins. So I'd recommend 4 to 6 weeks later. If you are, we're going to talk about PCSK9 inhibitors. Usually I'll tell people, let's wait till we've given 4 doses. Those are every 2-week medicines. So after 2 months, so I say after 4 doses, then we'll check a lipid panel to see if we get the full effect. So I'm trying to do that to ensure adherence. So let's start with case 1. So it's a primary prevention case. It's a 58-year-old man, comes in for routine care. He's not been seen for several years. And besides having hypertension, being overweight, he considers himself to be quite healthy. He does have high blood pressure and takes losartan. He has a family history of premature CHD. He tries to eat healthy, but is not exercising all that much. He used to smoke and he drinks alcohol occasionally. Review of systems is otherwise negative. He's 188 pounds, BMI is 27. Blood pressure 134/80, heart rate 70, otherwise normal exam. So the first concept, of course, is just what should we measure? And this seems like a no-brainer historically, but I would say this guideline throws us a couple extra bones here of what things we should be thinking about and that we need to learn to incorporate into practice. The other things I'll cover in this case will be the CPR framework, the prevent risk score, risk enhancing factors, calcium score targets, and lipid targets. So starting with measuring lipoprotein. So what's recommended? I already went through what's in the blue box here, screening kids, checking lipid panel every 5 years. Remember that people actually do not have to be fasting for a lipid panel. LDL cholesterol is not impacted all that much unless you have a really maybe high fat meal. But if triglycerides come back over 400 on a non-fasting panel, you probably should repeat it. And part of that is just because LDL cholesterol on the lipid panels that we all get is calculated, and the equations used don't do as good of a job when the triglycerides are over 400. Although the current one we use now, you look at your lipid panels called the Martin-Hopkins equation, it actually does a pretty good job, but it's still recommended triglycerides over 400, then get a fasting lipid panel. And then we should be reporting not just LDL cholesterol, but really thinking more about non-HDL cholesterol. I'll admit some of these things are new to me and I'm incorporating them into our lipid clinic. I haven't focused on non-HDL cholesterol as much as I should. I have not focused on what's in the orange box here, which is apolipoprotein B. You can see there are some scenarios where it's really useful to kind of think about residual risk by looking at other markers like ApoB. And probably ApoB should be checked according to these guidelines in many of our patients because we see a lot of people with triglycerides over 200, type 2 diabetes, and those who are at kind of an uncertain ASCVD risk. Steve, yeah.
We have a question in the chat.
Yes.
What have you seen for insurance coverage for lipoprotein a and ApoB?
Who asked that? That's a perfect setup because I probably would have forgotten to say it. So thank you for saying. So some of what we've done in Lipid Clinic has been driven the way we practice by whether insurance will cover some of these things or not. One of the reasons we had not checked a lot of ApoBs is because we've seen people with certain insurances come back and say that cost me $300. Lp(a) has been a similar problem. I think part of the reason these guidelines give a strong recommendation to these markers is one, with the hope that insurance will do a better job of covering these things. So to answer the question, I say, yes, we've had some problems with these. And I think even though it says LP(a) once in everyone, I can't give you a list of all the insurances that do or don't cover, but I think you need to be cognizant of that and talk to your patient about it. An LP(a) out of pocket is about $40 at a LabCorp request. So we often, when we know insurance won't cover, we'll print it and have a patient go and have that checked outside our system. I've been in touch with the lab, and we are getting a new platform throughout UC Health for lipid measurement which will change LP(a) and ApoB from being currently send-out tests to being tests that are run here on campus. That has potential, I think, to bring the price down. And then I would imagine as these guidelines get incorporated, especially LPA is a class 1 recommendation, that insurances will kind of be forced to cover. So thanks for asking that question. LPA, hot topic. I know there have been some really great talks over the last couple of years on campus. Greg Schwartz from cardiology has given excellent talks on LPA, and we've had visiting speakers. So just as a reminder, so this is an LP(a) particle, and it has an LDL backbone. So this is what an LDL particle looks like. That red part is ApoB, which is apolipoprotein B, and it's the structural protein that keeps this lipoprotein together. And then inside of these, you have triglyceride and cholesterol contained within the lipoprotein. The difference with LPA compared to LDL lipoprotein is this thing that has the KIV, or these kringles on it. So this gives it a unique property that's different than LDL particles. And because of that, well, we think about LDL particles as being atherogenic and getting into the blood vessel wall, LPA has some other unique properties to it. So it is pro-atherogenic because of its LDL-like structure, but it's also pro-inflammatory because this ApoA moiety, that kringled thing on the bottom, has oxidized phospholipids attached to it, which give it this pro-inflammatory aspect to it. And then lastly, and importantly, it's prothrombotic. And the reason for that is that this little ApoA thing at the bottom is structurally similar to plasminogen. So it competes with plasminogen for fibrin binding sites, and that inhibits fibrinolysis, or competes for inhibition of fibrinolysis, and then that leads to a higher thrombus formation. So this is still a minority particle. Even when you have a very high LPA level, you still have more LDL particles. But because it has all these properties, it can be quite damaging to people even who have pretty normal LDL particle levels, because it has these unique properties. So when we think about the pathology of LPA, we're thinking about, of course, ASCVD, but it's also implicated in calcific aortic stenosis. And there's exploring whether even some of these drugs that are in development for LP(a) could help people with calcific aortic stenosis from this problem. And then it's implicated in thrombosis as well. So many of you are checking this. And the question is, what do I do when it comes back? And what do these levels really mean? The first thing to think about here, I think most importantly, is that whenever you're checking LPA, there's a chance that it could come back with 2 different units, right? So this is why each box here has 2 different numbers. On our campus, if you order it here, it'll come back in milligrams per deciliter. That is actually not technically the gold standard. Hopefully we'll move to nanomoles per liter. The way to think about this is, so milligrams per deciliter is a mass, but nanomoles per liter is a particle number. So they're actually measuring different things, and they can be difficult to interchange because the mass of the particles, because the particles can be different size, can really be different even for the same particle number. The other thing is these numbers have different normal ranges. So the normal for LPA measured in nanomoles per liter is less than 75. But why does it say normal is less than 125? That's because the experts in this area think that that area between 75 and 125 might not be that clinically important. It doesn't really put you at much higher risk. And I think that's really important as we think about checking these in every adult, because you're going to have a lot of people where it comes back as, again, normal is less than 75 nanomoles per liter. It's going to come back at 90, and people are going to be worried because they're going to see that that level was high. But what I would tell them is we don't really think the risk is high until you get to 125. And the same goes for milligrams per deciliter. Normal range is less than 30, but they're saying here that normal range on your lab is less than 30 milligrams per deciliter. They're saying here that that 30 to 50 range is also still normal. So a little complicated there. We're going to talk about risk enhancers in a second. So once you get over 125 nanomoles per liter, we think about that as a risk enhancing factor, or above 50 milligrams per deciliter. And that equates to about a 1.4 time ASCVD risk in the primary prevention setting. A high risk person, and this applies to probably about 2 to 3% of the population, I would guess. High risk people have a measurement over 250 nanomoles per liter, over 100 milligrams per deciliter. The way I think about that is those values are about 3 to 4 times the upper limit of normal of our lab. So when you see 3 to 4 times upper limit of normal, that's a very high risk person. That's an ASCVD risk greater than maybe 2 times what they would be if they did not have that elevated. So the question is, in the primary prevention setting now, and I don't think the guideline does a great job of this, telling us what do we then do with this? We don't have targeted therapies for LPA. So again, conceptually, think about most of our bad particles are in the form of LDL, not LPA. So even when your LPA little a is really high, like you're this high risk person, LPA greater than 250 nanomoles per liter, of your total particles, probably only still 20% of those particles are LPA, maybe 15 to 20%. And that makes you think, this is why this first bullet here makes sense. Even if the LPA is really high and I don't have a drug, driving the LDL down by putting someone on a statin in that situation helps, because I'm shifting down still about 80% of their bad particles. So that's why that recommendation exists. It would be better, and in the future, we'll probably have drugs that lower LDL and LP little a all at the same time, but we don't have those yet. The other thing we sometimes do is, this is where you shift in primary prevention setting, going from, okay, well, my LDL goal here was 100. If I find that someone has a risk enhancer with LPA, I'm going to shift that target down just 1 notch. So I'll often see someone, I think their target's going to be 100. LPA is really high. I just shift it down in my note. I say, now their target's 70. And then if I had a target of 70 already and I find LPA is high, I just say, now their target's 55. It's not that complicated, but that's kind of what the guideline is telling us to do. Steve? Yeah.
I have 2 questions, one that's my own and one from the chat. So it sounds like perhaps you're suggesting that when the lipoprotein little a is elevated, then depending on if it's the 1.4, the 2 time range, shifting the LDL goal once or twice based on that.
Yep.
Something that I've done, and I've had colleagues at other institutions do, is take the prevent score, that 10-year ASCVD risk, and just multiply it by 1.4 or multiply it by 2, and then stratify their goal based on that. What do you think about that?
Yeah, interesting. I've never read that anywhere, and I don't think the guideline says that, but it makes sense given they did outline this kind of risk in there. What I had heard previously with the pool cohorts equation was that you only multiply it by 10%. The problem with that is that doesn't budge things very much. If your 10-year risk is 5.4 and then you add 10% to that, it just doesn't move the needle much. So I think that's an interesting idea. I haven't done any math. I don't do any math. I just shift their goal down to make it simple currently.
And what I described is not in the guidelines. That was us trying to figure out, what do we do with this?
Yeah, well,
because
exactly.
the guidelines are not very clear.
So I would say maybe even make it more simplistic and just say, I know my target's this. I'm going to shift it down 1 because they have this risk factor. Remember, LPA is genetically driven. About 20% of the population has a high level. And unfortunately, there's just not a lot you can do about it. Diet and exercise are not going to change this. And so it's something we have to live with and just recognize that person's at higher risk.
Can I ask the second question?
Yeah.
So this is coming from the chat, and it says, I have many healthy female patients in their 30s with high risk lipoprotein little a.
Yeah.
Their prevent score is low. They're too young for a CAC. Am I just giving them anxiety until they get a prevent score over 3% and I recommend a statin?
Yes. And this is unfortunate. This is where I wish the guideline had more guidance on this. And so Steve Simon is my cardiology partner, maybe some of you know, and we both, I think right when this came out, were kind of dreading that there was just this class 1 recommendation without much behind it for how to deal with scenarios like that, because that is so common. And so I don't know how to deal with it quite yet, because it's also hard to ignore checking things that are class 1 recommendations. And that's one of the general beefs with this guideline, is that there are too many class 1 recommendations, because there even feels like sometimes if you don't do things that are class 1, right, you can get dinged in a major way for that. But I think all we can hope for here is that we have a little bit better guidance, especially as I left this slide out, but there are many drugs in development here for high LPA, and some of those trials, so the initial trials, are all secondary prevention trials. So it will not be for that patient you just outlined who's in their 30s. However, as the drugs kind of proceed through these trials, as happens with everything, we start incorporating lower risk people into those trials. So already currently on campus, we have a trial for an oral drug, and 60% of that trial is enrolling primary prevention people. Still higher risk than the person you just outlined, usually primary prevention, high LPA with other risk factors, metabolic syndrome, diabetes, et cetera. But this is what happened with PCSK9 inhibitors and will probably happen in the LPA space as well, as if there's found to be efficacy of these drugs, we'll march through eventually having medication, then checking LPA will make sense. We'll know what to do for people. Targets are back. I think most people are happy about this. The only complicating thing is the LDL targets are easy to remember, but we also now have non-HDL cholesterol targets and we have ApoB targets. So I'm not going to belabor this slide, but want to provide this for you, that we have to think deeply about targets now. Okay, so we're still talking about biomarkers. So now I've told you there's LDL cholesterol, non-HDL cholesterol, and ApoB. These are confusing concepts, so I'm going to do a little physiology here. First, this is a slide that I show to medical students when I'm teaching on this topic, and I have to go back and look at it all the time to think about what are those ApoB-containing lipoproteins. So the first is we always talk about LDL. And again, I told you LDL particles are about 70 to 80% of our atherogenic particles, but other particles we have are intermediate density lipoprotein. We don't measure that. VLDL, those are the particles that contain triglycerides when we're looking at triglycerides on the lipid panel. And then chylomicrons are those really big particles that contain triglycerides that get into our bloodstream after post-meal. And all of these are ApoB because they all have potential to get into the blood vessel wall. So what are the definitions of these things? You'll notice on my slides, I, for the most part, do not say LDL, but I say LDL-C. Why is that? The -C is cholesterol. I'm talking about not the particle when I say LDL-C. That would just be LDL. LDL-C is the cholesterol within those particles themselves. Non-HDL cholesterol, similarly, is the cholesterol in all atherogenic particles. That's on all of our lipid panels where you just subtract out HDL. Why do you subtract out HDL cholesterol? Because we don't think that HDL particles are atherogenic. So it gives you this rough estimate when you look at non-HDL of all particles beyond LDL. So what this picture is depicting. But it's a bit of a crude measure. So a more accurate measure, and this is why ApoB has been recommended to be checked, are looking at just actually all these particles that have ApoB on them. So sometimes people refer to also this idea of remnant cholesterol, which is the portion of the non-HDL cholesterol that's not LDL-C. So take non-HDL that I just told you, which incorporates LDL-C, and get rid of the LDL. And now it's like in this picture, all those other things that are here. So we're not measuring them directly, but you can get a sense that someone might have these particles. So the take home here is that ApoB is counting particles, and LDL cholesterol, non-HDL cholesterol, are looking at the cholesterol contained within certain particles. So when do you get ApoB? So in other words, who are the people who might have this other risk, like these IDL, VLDL particles that are high that I have to worry about as being atherogenic? They're the people we see all the time that I already mentioned: triglycerides over 200, metabolic syndrome people, type 2 diabetes, people who have elevated Lp(a) because Lp(a) is an ApoB-containing lipoprotein. So this is kind of a lot, but I think it's important if we're going to do this in clinic and actually check ApoB. Rita, yeah.
When we're using this triglyceride level, is this a fasting triglyceride or
Great question. She asked, should be a fasting triglyceride level? I say it should be fat. Yeah, I would use a fasting level for this. So this patient's labs return. So I'm just going to put in here all the things we just talked about. So the LDL cholesterol is 134. In isolation, that doesn't look so bad. None of us get freaked out when we see that. The non-HDL is 182. The ApoB is 130, and the Lp(a) is 130. So how do I now digest that? So there's a rule of thumb. So the non-HDL cholesterol should usually be, this is crude, about 30 milligrams per deciliter higher than LDL. And ApoB is usually about 30 milligrams per deciliter lower than LDL. This is, again, very crude, but it helps when you look at this example. So let's use that. So LDL cholesterol is 134. So 30 points above would be maybe 154, but this patient has 182. So that's telling me there's some of these extra particles. This person has this residual risk here. And again, that's already on your lipid panel, so we should pay attention to it. ApoB we have to measure, and hopefully your patient doesn't get a bill, but that person's ApoB with an LDL of 134 should be more like 100, and it's 130. So that corresponds that the non-HDL was high because of extra particles, the ApoB is high because of extra particles. One of those extra particles is this person has a high Lp(a). So this is how we can think about all this together. So now what? The guideline recommends a framework now for how to deal with that. That was probably the most complex part of the talk, by the way. CPR framework, calculate. We already know how to do that. We're going to personalize someone's risk by thinking about risk enhancers, and we're going to reclassify using coronary artery calcium score. Slip of the tongue. Okay. Prevent score replaced the pool cohorts equation a couple years ago, and again, this calculator can start being used at age 30, which is advantageous compared to the old calculator at age 40. And it incorporates several things that are important that the previous pool cohorts equation did not incorporate, including you can put the zip code in for your patient. So that gives you some information about social determinants of health. You can input their urine microalbumin, or urine albumin, creatinine ratio. If they have diabetes or prediabetes, you can put in their A1C. So all this gets adjusted for some clinical factors or life factors that previous calculator did not take into account. And what came out of this, when they created the prevent calculator, what they found was that the threshold for treatment for all these numbers were lower. So you'll see that we have to recalibrate now what groups we consider low risk, borderline risk, intermediate risk, and high risk. So these numbers are different. We're all very used to kind of that borderline intermediate risk when we start statin treatment being 7.5%. That's not the case now. You actually, when you see a score of 3% with prevent, that person is borderline. You're starting to think about statins. I'm going to show this on the next future slide here in a second. Intermediate risk starts at 5% and high risk is over 10%. So we want to use these new prevent thresholds. You've probably all been to the website. This is what it looks like. I took our patients' numbers, I put them in. So they're the results for ASCVD risk here, 10-year risk is 6.2%. So this person is intermediate risk. And one thing I told you, one of the main things in the guidelines is looking at long-term prevention. And so they don't give a lot of guidance on how to use the 30-year risk calculator, but I think it's something we should at least think about a little bit more. So this patient's 30-year risk is 25.4%. Over 10% is considered significant, but really probably where the 30-year risk matters is not so much this patient, which is already intermediate risk for 10-year risk. It's more that younger patient where you do the calculation and they're low risk, less than 3%. So they're young. They're that 30-year-old person that Steve mentioned. Their risk might be 2.5%, but maybe their 30-year risk is 20%. So you're still talking to them about that, and you're considering things that don't get factored into the calculator, right? So many patients come to my lipid clinic. I just throw the calculator out when they tell me their horrendous family history of heart disease. I say, let's just start a statin. Let's start something. I mean, and probably many of you do the same thing, and it all goes out the window. But here we can look at 30-year risk a little bit. To go through this a little bit quickly, there have obviously been publications thinking about how this new prevent score affects the general population. And again, I mentioned that we now have lower numbers that we're focused on. So just to show this again, I think it's a key point. We have to learn these different prevent ASCVD thresholds. So going through some of the flow charts, and there are many of them in this guideline, we're thinking about patients who are between ages 30 and 75. And we're doing these calculations, especially if your LDL is between 70 and 189, and we're estimating their 10-year score. Low risk person, we're of course going to discuss their therapy options. One thing that's key, I think, to remember for someone who calculates as low risk is that if your LDL cholesterol is above 160, you should not ignore that. In the previous guideline, that was considered a risk enhancer. Here, a little bit more strongly, they actually say you should probably treat the person. The reason for that is that probably if your LDL is above 160 and it can improve with, say, diet and exercise, one, there could be something genetic driving it. It could still be familial hypercholesterolemia, even an LDL cholesterol of 160. The second is those patients are in epidemiologic studies still at higher risk, and it affects probably 6 to 10% of adults still have LDLs like this. And they're probably in the upper 5% of the population when you see an LDL of 160. So low risk, LDL over 160, consider a moderate dose statin. Borderline risk, 3 to 5% 10-year risk. Think about, I'll just let those go. This is where you really are going to look at risk enhancing factors, which I'll talk about in the next slide. And you're going to consider doing coronary calcium scores. The same goes for the intermediate risk when you're between 5 and 10% risk. I thought it's interesting here that they don't have the purple box also under intermediate risk for risk enhancing factors. I'll tell you that I still would very much think about risk enhancing factors in someone who's intermediate risk, especially because if they have a lot of them, that person might be someone I'm shifting their LDL goal down because they have such a high cardiovascular risk based on other comorbidities. And then high risk, greater than 10% 10-year risk, we should be using high dose statins. Again, if we're looking at non-HDL goals, think about that being your LDL cholesterol plus 30, and you're looking for discordance there. Risk enhancing factors haven't really changed much since the last guideline. So many of you are, probably most of you understand these and have been thinking about these things when you've seen your patients. So I'm just outlining them here. In red, I've highlighted that coronary artery calcium score really takes a front and center seat here, though, as a biomarker that we should be thinking about. So to get into that a little bit, what this guideline recommends is that coronary calcium scoring should be done in men age over 40. Again, we're thinking about this in our borderline and intermediate risk patients, and for women at least age 45, because this can help improve our risk assessment for those who fit into those borderline and intermediate categories. Again, probably many of you have ordered coronary artery calcium scores. Remember, there's no IV contrast given. You don't have to take a beta blocker beforehand like you would with a CT angiography. The radiation exposure is comparable to mammography. Typically, insurance will not cover these studies, and they cost $75 to $150 out of pocket. Here on campus, it's about $150. We often send patients to Envision Sally Job or Health Images for more like $75 to $100. If someone's score comes back as 0, that's where you're going to use it to help decide whether you're going to start a statin or not. But it doesn't mean if your score is 0, it doesn't mean you're just off the hook forever, that we're never going to think about your prevention again or even checking a coronary calcium score again. So if you're low risk and you have a calcium score done, the recommendation is to get another calcium score probably in about 5 years to see if they've hit that inflection point where they start showing subclinical atherosclerosis. If you have intermediate risk or you have diabetes, you should probably think about doing another calcium score 3 years later after a score of 0. Statins may increase coronary artery calcification. What does that mean? We have hard plaque and we have soft plaque in our arteries. Coronary calcium score does not show you if someone has soft plaque. The thinking is that statins stabilize soft plaque and turn it into more stable calcified plaque. So that's a reason to not always just get serial calcium scores, because when someone's on a statin, I tell them the score might go up, but that is not necessarily a bad thing. It might mean stabilization of some soft plaque that was more vulnerable to rupture previously. So a kind of a complicated thing to have to explain to patients, but I think it's necessary because people usually say, well, what, can't we just recheck this? And isn't my calcium score going to go down once I'm on lipid lowering therapy? And it's not. Okay, so calcium score comes back at 0. This is reasonable then to defer statin therapy among lower and intermediate risk adults. The guideline gives us some guidance on what to do with certain calcium scores. So whenever you get a score, you get the absolute score, but you also get a percentile, which is percentile compared to the person's age and their gender. And if you're less than 75th percentile or a calcium score between 1 and 99, the recommendation is to start a moderate intensity statin. If your calcium score is 100 to 299 or over the 75th percentile for age and gender, you should probably start more like a high intensity statin. If you're over 300 to 999, you're also going to usually start a high intensity statin and drive the LDL cholesterol below 70. But this is a scenario we might want to think more about residual risk as well. And does this person actually deserve to have an even lower LDL cholesterol goal, potentially less than 55? And then if your coronary calcium score is above 1,000, which is the case for some of our patients, you should start high intensity statin, probably drive LDL below 55, and think about them really as a secondary prevention patient. There's also some mention in this guideline about incidental CAC, and I'm going to skip that for the sake of time. But the point here is if someone gets a CT scan for another reason and coronary artery calcium is noted, that we should not ignore that, and we should just think about starting them on usually moderate intensity statins. To sum this case up, we did risk assessment. This is the longest case as well. 10-year risk was 6.2%. That's intermediate risk. This person actually, when we went through it, had a lot of risk enhancers, right? I didn't mention this before, but you should always exclude secondary reasons for high LDL. One could be severe hypothyroidism, so you should check a TSH. Kidney and liver disease can alter LDL cholesterol, so it's checking a CMP, and proteinuria can raise LDL cholesterol and triglycerides, so we always get a urinalysis. So those are basic labs you should get in all patients. And the initial management would, of course, be lifestyle things in this patient, but most likely starting at least a moderate intensity statin. But I would say, look at all those risk enhancers that you've identified now. And it's very reasonable based on this guideline. So they say to potentially drive that LDL cholesterol goal less than 70. So what we used to think is a secondary prevention target, but doing it here in the primary prevention setting. Follow up again, 4 to 12 weeks, usually 4 to 6 weeks in our clinic. Assess their adherence. I will say for assessing adherence is where I do think that sometimes doing those percentage calculations, what was the LDL before, what was it later on, can be still useful for identifying people maybe are not taking their statin regularly. Because you kind of know what range the LDL should drop, right, with a certain statin therapy. And if they're not there, then it's often an adherence issue. Only check CK levels when someone really has true muscle symptoms. And then if you need to intensify therapy on top of the statin, really consider doubling the statin dose. Remember, when you double a statin dose, it lowers LDL only another 6%. So it feels good to jump something like a Torvam going from 40 to 80. You might only get an LDL reduction of 6%. So I would really encourage people to use a lot more ezetimibe. Ezetimibe is usually 20% LDL lowering, cheap med. The best thing that could happen to the field of lipidology would be if they made combinations of statin with ezetimibe in one pill, frankly, and they really don't do that any longer like they used to. But adding ezetimibe is key. And then for some of these people, just thinking about, am I getting coronary calcium scoring, and am I continuing to assess their risk over time? Secondary prevention, 66-year-old woman, ASCVD and hypertension. She's doing well. She is on atorvastatin 80. She has no clear premature ASCVD in her family history. Social history, heart healthy diet, walks 45 minutes per day, non-smoker. Blood pressure is 130 over 80, BMI is 20 to 6, otherwise normal exam. You get her lipid panel, LDL cholesterol 75, non-HDL is 100. So that's kind of in that 30 ballpark. So kind of what I'd expect. But the question is, in a secondary prevention setting, is this adequate? So I've already touched on this, that we need to define people now as very high risk, but what does that actually mean? So in these guidelines, very high risk would be someone who has greater than or equal to 2 major ASCVD events, or someone who's had 1 major event and greater than or equal to 2 high-risk conditions, which are the things listed here. Older age, they had bypass surgery before, currently smoking, diabetes, history of heart failure, hypertension, and those who've had LDL greater than 100 despite maximal tolerated statin ezetimibe, they're still high risk and you need subsequent therapy for them. Again, very high risk patients. Now the goal is less than 55 milligrams per deciliter. We kind of knew that the guideline was going to go this way because European guidelines were published years ago. We don't have time in this talk to go through all the evidence for lower is better, but a lot of that's come out of the PCSK9 trials that show that if you drive LDL down below 55, it really is beneficial for this group. And so in certain other international guidelines, including like the Indian Lipid Guidelines, they actually recommend for some high-risk patients LDL cholesterol is below 40 milligrams per deciliter. Our guidelines just didn't go that far, but I think 55 is appropriate. So once you identify these patients, LDL less than 55, generally you'll need to add ezetimibe to a lot of these patients' statins, but you can also consider PCSK9 monoclonal antibodies. In some patients who are close to goal, it may make more sense to add bempedoic acid, which I'll talk about briefly. And then this gets asked quite a bit, what's the use of this drug inclisiran, which is kind of like the denosumab or Prolia of lipid-lowering drugs given every 6 months. And the answer there is it's not as strong as PCSK9 inhibitors, but you should consider giving it in those who are intolerant to PCSK9 inhibitors or do not want to take shots every 2 weeks. Another common question that you would have in this scenario, well, is too low bad? Can we go too low? And so far, we do not have evidence actually that going very, very low with LDL cholesterol levels is at all harmful. This is a sub-analysis of the Fourier trial, which is one of the PCSK9 monoclonal antibody inhibitor trials, and subset of patients in this trial. So about 40% of them got their LDL cholesterols down between the levels of 20 and 40. And that's represented here on this figure by the red graph. So it shows that actually, if you do the sub-analysis here, those patients actually had better CV death, MI, stroke, and hospital admission composite outcomes than those who still were at relatively good control with LDLs near 70, but you did better the lower you went. What about cognitive outcomes related to low LDL cholesterol? So in this paper from now a couple years ago, they looked at patients who had a median LDL cholesterol of 35, and they did neuropsych testing, and they found no change in cognitive function after 5 years of follow-up from having LDL cholesterol levels this low. And there was no change in executive function for those who even had LDLs below 25. So the guideline says evidence indicates long-term safety and efficacy of LDL cholesterol to a median level of 30 milligrams per deciliter over 8 years of follow-up. There's no signal to suggest that de-escalation of therapy is indicated for very low levels of achieved LDL cholesterol. A recent paper in the New England Journal of Medicine called the EASY-PAVE trial. This was a trial of 3,000 patients with established ASCVD, and they actually did look at achieving a target of LDL cholesterol below 55 versus the control target of less than 70, and the 3-year MACE was 33% lower in the intensive arm. Again, a recap on PCSK9 monoclonal antibodies. I think probably many of you are starting to use these. The insurance coverage has improved, and now we have guidelines that support using these drugs more often. So as a reminder, these drugs help reduce the degradation of LDL receptors. So our LDL receptors are always being recycled through the liver. This allows us to upregulate more LDL receptors to capture more LDL lipoproteins in the bloodstream and drag them into the liver and then destroy that cholesterol. And they're really well tolerated and robust drugs that tend to lower LDL cholesterol by 50 to 65%. They're extremely effective on top of statin therapy and ezetimibe, and they have indications for known clinical ASCVD, familial hypercholesterolemia, and now also they should be used in patients who are statin intolerant and not at goal. We have 2 drugs in this class, evolocumab and alirocumab, and they're dosed as shown here. These clinical outcome trials, you've probably all seen these because they're several years old now. Again, Greg Schwartz was from cardiology at the VA, was the primary author on the Odyssey outcome trial. These were really large trials that showed that these drugs are safe and effective for reducing cardiovascular risk in high-risk patients. I'll go through this a little bit quickly, but inclisiran is also called Leqvio. Has anyone prescribed this in the room? I don't even prescribe it all that much because the monoclonal antibodies are better. They have more robust LDL cholesterol lowering. You'll see here, we often only see maybe 40-45% LDL cholesterol lowering with this drug, but it is amazing to me that we have medications like this that we can prescribe. An siRNA that can be given every 6 months that's very safe and well tolerated that reduces LDL cholesterol robustly. What would have been nice is if, 1, patients could give this drug themselves at home, 2, if it was less expensive, and 3, if it had a little bit more LDL cholesterol reduction. We're just not quite there yet, but maybe in the future we'll have siRNAs that will meet those criteria. a recent trial that came out, not to belabor all these different trials, but just to show you, kind of as I talked about with Lp(a), as these drugs are on the market longer, we start to progress to higher risk primary prevention groups. And this trial has gotten a lot of press recently, the VESALIUS-CV trial. When the Lipid Guidelines came out 2 months ago, the main authors of the guideline published at the same time the guidelines came out an editorial that said, we're happy these guidelines came out. They were years in the making. They're already behind the times because this paper had just been published and they were not able to incorporate it into the guideline. And what it's really showing is that there's benefit in giving a high risk primary prevention group. So these are patients who have positive coronary artery calcium scores, but no events, or people with high risk type 2 diabetes over about 5 years, giving them PCSK9 inhibitors on top of statins, that it also reduces cardiovascular events in the primary prevention setting. So I think kudos that this trial was done, right? Because we don't get a lot of primary prevention trials. This is probably hundreds of millions of dollars to have 12,000 patients in the trial. So at least we have some evidence evolving in this space. Secondary prevention case, going back to it. So this patient had ASCVD that was established, has hypercholesterolemia. Why did she have premature and recurrent ASCVD? Probably we should check out Lp(a) in this person because maybe that was one of the drivers here. Per the new guideline, she's at very high risk because if you remember, she'd had multiple events. So we're going to drive her LDL below 55. And just to sum up the options we already went through, you can intensify statin therapy. Oftentimes, even Atorva 80, if someone's on that, I'll switch it to Rasuva 40. It's a little bit stronger. Maybe it's only a couple percentage more reduction, but it can be worthwhile to do that if that helps you get to goal. Add ezetimibe first on top of statins. Generally, I'll do that. And then consider adding these other medications that we've already mentioned. Can you go straight to a PCSK9 inhibitor without adding ezetimibe? The companies would like us to do that. I don't think that's the right thing to do for most people. I think ezetimibe is a well-tolerated, cheap drug. 20% LDL lowering is nothing to bat an eye at. And so usually I will add ezetimibe first, and then I'll add PCSK9 inhibitor. If then that person gets a really low LDL, then I'll sometimes peel off the ezetimibe after that so that they're only on statin and PCSK9 inhibitor, not on 3 drugs. Last case, 58-year-old man. He had an acute MI. He's had a stent placed. It was 3 months ago. He was discharged on Atorva 80, but developed significant muscle aches. The symptoms resolved after discontinuing that medication. His cardiologist checked a CK, which was normal, and had him try pravastatin 40, which also led to muscle aches. Otherwise, he's been fine, but he's off the statin now. Family history: father had a cabbage at age 65. He's working on a heart-healthy diet, walking 30 minutes a day, non-smoker, occasional glass of wine. Labs show now off statin, LDL cholesterol 141, clearly not a goal for someone like this. Other labs look fine. First, statin intolerance definitions get so confusing. What's a myalgia? What's myopathy? Let's go through those quickly. So SAMS is a term that's been used in the statin intolerance space to help us try to understand this categorization, because a lot of people will say they've had statin intolerance because of muscle issues, but you really have to dive into that. And I'm sure many of you do that. But just as a reminder, myalgia would be some unexplained muscle discomfort, but if you check a CK level, it's perfectly normal. Myopathy would be myalgias, but the person also has muscle weakness. Their CK is not mentioned here because that's not part of the definition technically of myopathy. Myositis would be muscle inflammation, so you could have pain and weakness, but you actually have the elevated CK. And then myonecrosis is the thing we fear the most, where you actually find that CK elevation, and you can see here that can be classified as mild, moderate, or severe. And of course, in severe episodes of myonecrosis, you can have someone who goes into rhabdo and has an acute kidney injury. Other adverse effects of statins, of course, hepatotoxicity, we're really only get concerned. We all see the LFTs go up with statins. That's not a reason to stop them in most cases, but when the liver enzymes get above the three times the upper limit of normal, you should probably switch to a different statin or discontinue it for a while before you re-challenge. I'm not going to get into this, do statins cause diabetes, but maybe if I have time at the end, but that's a bigger topic. So my point in putting all that together was I really like this. This came out actually before the guideline, and it's from the National Lipid Association, where they actually try to help us define what statin intolerance is. And they give us a better, I think, definition than we've had previously for this entity. So here it says statin intolerance is defined as one or more adverse effects associated with statin therapy, which resolve or improve with dose reduction or discontinuation, and can be classified as complete inability to tolerate any dose of statin or partial intolerance. So I think this is kind of key, because so many times we just put the label of statin intolerant on patients, but we haven't thought deeply about it. This encourages you to do that. Complete intolerance would be this person is unable to tolerate any statin or any regimen. They've tried multiple statins. They cannot even take a atorvastatin 10 milligrams 1 day per week without getting symptoms. That's complete intolerance. Partial is what we should be doing, is still trying to get people on statins, as I know, again, many of you do, 3 times a week, 4 times a week, 2 times a week. We're playing with these things because there's still benefit in having them on some degree of statin. So that would be partial intolerance. And I use these terms. They're not ICD-9 or 10 codes for these terms, but I will put that in my note to really clarify. This is true complete intolerance. This is partial intolerance. The other reason I think that's important is because if you are going to start using more PCSK9 inhibitors and advanced therapies, insurance companies are going to want to see this in your note, that you actually really gave it your all with statins. The nocebo effect, of course, the expectation of harm, really impacts our use of statins in this country. And that's its own diatribe about the internet that I could go into, but I won't currently. Again, think about qualifying a person as statin intolerant. The guideline says at least a minimum of 2 statins has to be tried, and that we should keep trying statins to lower people's risk. So a couple more minutes here. What if your patient is statin intolerant? We already went through some of this. Check a CK if they have muscle symptoms, maybe decrease the statin dose, try a different statin, try the statin less frequently, maybe even something like rosuvastatin 5 milligrams once weekly, and then gradually ramp it up. What I often tell patients in clinic, I'll say, I know you've had a bad experience with statin. Doesn't mean you'll have a bad experience with everyone if we switch it. I know you're nervous about it. Why don't we start once weekly? If things are going well after a month and you feel okay, why don't you increase it to twice weekly? Why don't you increase it to 3 times a week? And I kind of give them a little, opportunity to do that themselves. And then I'll say, we'll check a lipid panel 3 months from now, and you'll communicate about what dose did you actually get to. So I give them a little bit of time to just figure it out themselves, how comfortable they are with going up on the statin. Consider CoQ10. A lot of our patients take these because of things they read. I don't know if I haven't tended to recommend CoQ10, even though I've seen people who seem to benefit from it. Trials have not panned out to show that this is actually useful. And then adding non-statin therapies. For the sake of time, I'm going to skip this slide and talk quickly about, so we have bempedoic acid, which I mentioned. This is a drug that works upstream of where statins work. It's an oral pill that is generally well tolerated, but it only lowers LDL cholesterol maybe about 20%. When I prescribe this, I'm thinking about usually replacing a moderate dose statin in someone, and therefore I'll prescribe it in the combination form, which is called Nexlizet. That's bempedoic acid plus ezetimibe, 40% lowering, replaces a moderate dose statin well, and can get people to goal. We have a cardiovascular outcome trial showing the benefit of this drug. Problem with it is that if you've had gout before, it can increase your risk of gout. And the thing I forgot to put on this slide is it's been implicated in some patients in tendon rupture, which is not a fun thing to happen. And that, especially for our very athletic patients, makes me a little bit worried about this medication. I'm about out of time, so I think I could stop here probably.
I think we have
I'll take
time for one question. I'll walk over to you, Paul.
So what do you do with patients who are really old, getting more and more people over 80? What do you recommend for that?
Great. What do I do for people over 80? And the guideline doesn't give us much on that. I try not to be ageist by first saying that just because you're 80, you should stop your statin. We, of course, don't have evidence, but I'll just tell, maybe to answer that, I'll tell an anecdote really quick. I had a lady come to me. She was 85 years old. and said, I'm coming to you because I want to discuss starting a statin. I said, why are you here? She said, my mother died of a stroke at age 105. So, I kind of put it in that perspective of this is someone who has longevity in their family. She was in great health, cognitively doing well, active, and she thought I might have 20 years of life left. I would say lipid lowering therapy for 20 years, doesn't matter what your age is, it could still potentially benefit for that person. So I think we just have to, this is the art of medicine. And if someone has a lot of comorbidities and a lot going on with their health, when I see them once they're 80 years old, I will say, is it time to back off? Maybe it's not stop everything, but expensive drugs like Repatha, if they're also on ezetimibe and statin, I'll start backing off the medications in conjunction with shared decision-making there.
Dr. Saxon, thanks so much for joining us today. Clearly a lot of practical advice for what we're doing every day in primary care. So thank you.
Thanks for having me.